Good evening, everyone, and welcome to the first Australian and New Zealand Vasculitis Society GP webinar. I'd like to begin by acknowledging the traditional owners of the land on which we speak today, wherever that may be for you. For me, that is the Boonwurrung people of the Kulin Nation. I'd also like to pay my respects to elders past and present. Hello, my name is Jessica Ryan. I'm a nephrologist and I practice at Monash Health in Melbourne. I have an interest in vasculitis and one of a few physicians that take part in our vasculitis service there. I'm also on the board of the Australian and New Zealand Vasculitis Society. My co-chair is Dr. Anita Munot, who is a GP who also works in Melbourne, and amongst many other things, she's currently the chair of the RACGP Victoria Council, and it's my great pleasure to welcome her here today. We have three fantastic world-class speakers today, and we very much hope you find the talks useful. ANZVASC is very grateful to have received an educational grant from CSL Vifor, which has allowed for tonight to go ahead. So we thank their team for making this evening possible. We're going to go through the talks one after the other, but there is plenty of time for questions at the end. I encourage you to ask questions. We're going to use the Q&A box, which should be at the bottom of your screen. Our speakers may answer some questions in the text as we go along that are straightforward. Otherwise, we'll try and get to things in the chat at the end. This will be recorded. It will be sent out via email to registrants later in the week, so look out for that in your inbox. We also very much welcome feedback about the event tonight. We do have plans to have more, so please do fill in the survey that will be sent to you. So moving on to our first speaker. So Tony Samuel is our first speaker. He is going to do a talk entitled When to Suspect Vasculitis. Tony is a Sydney-based rheumatologist with subspecialty clinical and research interest in vasculitis. He's currently a staff specialist at the Prince of Wales Hospital in Randwick, Sydney, and he coordinates the rheumatology vasculitis service there. Thanks, Tony.
Thanks so much, Jess, and thanks Anita and the team for, as Jess has mentioned, inviting us to do an ANZVASC presentation. The first talk today is really an introduction to vasculitis, and we've entitled it When to Suspect Vasculitis, but it's a bit of a sort of a cheat sheet and a bit of an approach to thinking through a patient who you may think has vasculitis. What are the next steps? And then obviously my co-speakers will be discussing in greater detail the more common and significant vasculitides, giant cell arteritis and ANCA-associated vasculitis. So I've started this discussion today with three illustrative cases, and you may recognize what these cases are as we go through. So the first one is an 80-year-old Caucasian female, and she was initially reviewed in primary care for a headache, which she described as a parietal and occipital headache. So we're seeing new headache in an older person. She had scalp tenderness, and she also described some new night sweats. Over the next couple of weeks, she started to experience some new symptoms. She started to experience jaw pain when she was chewing food. She then experienced more concerning symptoms of transient diplopia, 4 episodes, each of which lasted around a minute. And then finally, she had 2 episodes of monocular vision disturbance that was affecting her left eye, and she had a whiteout of the eye lasting 30 seconds on both occasions. She was investigated through her general practitioner. Initially had a CT brain performed, which showed some evidence of sinusitis and had a course of antibiotics which was not effective. Blood tests showed elevated inflammatory markers and an anemia of chronic disease. And after those 2 episodes of vision disturbance, the penny dropped. And the working diagnosis at that point became giant cell arteritis, and very correctly, her GP recognised the need to do 2 things. Recognised the need to firstly to start empirical treatment with prednisone 50 milligrams to protect her from further vision disturbance and further permanent vision loss, and sent her to emergency department due to the fact she'd had vision symptoms with GCA. And I think one of the questions that came up when we were looking at these slides was, what's one of the key practice points here? Should you start prednisone before organising a biopsy and further workup in someone you suspect may have GCA? The answer is yes, and that was correctly done in this case. The second case is a 55-year-old man. So he actually presented, and I met him when he was in emergency department, having been sent in from his general practitioner. So he'd presented with 3 weeks of arthralgia. He'd had 6 days of a non-blanching rash on the buttocks and legs, which is probably raising your suspicion for palpable purpura or a cutaneous form of vasculitis. And you can see here his lesions were actually not all that prominent. They were more petechial, but they were elevated, suggesting they were palpable, and they were indeed non-blanching. He was lethargic, and most significantly in this case, in terms of working out where he should be managed, he had a new cough with occasional streaks of blood. On examination with his GP, it was noted he had palpable purpura, but otherwise he had a normal examination and indeed was normotensive. So at this point, his organs had been screened, and it was recognised that he did have potential for a major organ to be involved, namely his hemoptysis, and he was sent to emergency department. And at that point, his CRP was found to be 100. He had normal kidney function. And I wanted to raise the next test, because these are the things that you should be doing in general practice, is then looking for the urine, because that's one of the major organs which can be clinically missed. So we always check for microscopy with hematuria, and I usually send for an albumin-creatinine ratio, but a dipstick will also show proteinuria in these cases. And sure enough, even though he had normal kidney function, he had red cells in his urine, and he had low-grade albuminuria. So at that point, we already thought the kidneys are probably involved, and we were going to admit him at that point. Symptom-based guided imaging is also important. So in a man with hemoptysis, we're concerned that he may be developing pulmonary hemorrhage, vasculitis in his lungs. And sure enough, he underwent a CT scan, which just showed some very early signs of ground glass opacity. And in the clinical context, that did represent alveolar hemorrhage. So he was admitted to the ward. He underwent a skin biopsy that afternoon, as well as a renal biopsy later on that early in that evening. And both of those confirmed that there was indeed vasculitis present. His ANCA results, so he sent off the panel of blood tests, including ANCA, and they were positive with a PR3, in keeping with the diagnosis of granulomatosis with polyangiitis, which Dr. Chen Aopei will be discussing later on today. The important point here that I want to raise is that while he was in hospital, and despite starting treatment, his creatinine rose quite quickly to a peak of 175. So you can see here the value in doing the urine studies to identify the vasculitis is involving the kidneys, and that's the need to move quickly, and in this case send the patient to emergency department. So he had lungs, kidneys, skin and joints, and he had induction therapy for major organ GPA while he was in hospital, and then was obviously discharged for longer term follow-up with his specialists and with his GP. And this is a chronic disease, and he's still on maintenance treatment 4 years down the track. The final patient for this case is a younger man, a 33-year-old, and he presented to his GP with this non-blanching palpable purpuric rash, which is kind of down here in the lower legs, but also this livido, and livido is sort of a lace-like rash higher up in the thighs. And this was non-blanching the bits down towards his legs, and they were also palpable. He'd had ankle pain, he'd had night sweats, and importantly, he'd been using recreational drugs at parties. So once again, I suppose when you're seeing a patient like this and you're thinking, could this be vasculitis? And the answer is yes, it could be. It's really important to screen for major organs. And he had a negative screen, so he didn't have any cardiorespiratory symptoms, he didn't have any neurological symptoms, GIT symptoms, and indeed he didn't have any ENT symptoms either. His blood count and his urinalysis were normal. His CRP was 45. So this is the type of patient who you very well could, in conjunction with a specialist who you work with, say, look, I'm going to start the workup in primary care, knowing that I've got a bit of backup here, but this is the sort of patient who certainly can be managed outside of a hospital setting. In terms of investigations, so this is the type of time that we do a broad screen for potential causes. He had an autoimmune and infective serological panel, and I'll discuss that later, what to do when you suspect you may have a patient with vasculitis. He underwent a skin biopsy, and this is really important because, in general practice, you guys are really expert in doing skin biopsies, and he was shown to have a small vessel vasculitis on skin biopsy, and he had immunofluorescence staining, which was negative for IgA, meaning this is not an IgA vasculitis, not Henoch-Schönlein purpura. And indeed, on further history taking, it became quite clear that he was actually using cocaine frequently. So at this point, he was really just had symptomatic management while the test came back. And finally, a week later, it became clear that his autoimmune serology was negative. He abstained from cocaine and everything settled down. And he had a cocaine-induced vasculitis. So when to suspect vasculitis when you're seeing a patient? So I've listed the common presentations where vasculitis comes up. So giant cell arteritis is a condition that affects the elderly, so new headaches in elderly, and I'll talk about that as will Professor Hill. Then with the next group of conditions is this sort of palpable purpura, small vessel vasculitis type presentation. And the two things which go with that are patients who've A, got palpable purpura, or B, those who've got progressive multi-system organ impairment in the absence of an infection. And finally, the one that often is raised as possible vasculitis, although is almost always not vasculitis, although it needs to be low down, but in the differential list, is patients with recurrent atypical vascular events and ischemic events. So I really don't want to labour on the details of the differential diagnosis when you're thinking about vasculitis, because it's quite a complex area, other than to say the way that we think about these conditions is really by trying to divide them up into groups, because we're dealing with a whole large number of variety of conditions that in many ways can look quite similar. So how do we think about them? So we think about firstly in terms of the vessel size, so large vessel vasculitis, and the most common one is clearly giant cell arteritis. In younger patients, a very, very rare syndrome is called Takayasu arteritis, and it's unlikely that you'll see that in clinical practice. Medium vessel vasculitis is very unusual actually in clinical practice, polyarteritis nodosa. But small vessel vasculitis is something that you will see or certainly will think about in patients who present to you. And I grouped it up into 6 groups. So I think about anchor vasculitis, which is obviously going to be discussed further today. I think about it in terms of connective tissue diseases that can cause vasculitis, of which there are 3. There's lupus, there's rheumatoid arthritis, and there's Sjogren's syndrome. There are the other immune complex type vasculitides, IgA vasculitis and cryoglobulinemic vasculitis. And then there's 3 which are not typically autoimmune. So we see infection causing vasculitis, particularly viral infections. We see drug-induced vasculitis, similar to the cocaine-induced case that I showed before. And we see some malignancies, particularly hematological malignancies, being associated with vasculitis due to erroneous mechanisms of the immune system, particularly in people with myeloma, MGUS, and lymphomas. So moving on to the first group. So when to suspect giant cell arteritis. And again, I'm really just doing a very brief sort of one slider here. But when to think about it, when you see a patient who's over the age of 50 and the mean age is 73, it's more common in women and more common in people of Caucasian descent and certainly of European descent. It's exceedingly rare in patients from an African heritage, and it's pretty rare in patients from an Asian heritage as well. So it's really in that sort of European background group that we think about it as being the thing to think about. Patients present with one of 5 cardinal symptoms, namely a headache or scalp tenderness, jaw claudication, vision disturbance, constitutional upset, and or polymyalgia rheumatica. And they only need to have one of these, but the more they have and the more typical they are, the more likely it is that they may have GCA. And we see an elevated CRP and or ESR in 96% of patients, which means that almost everyone will have a high one or both of these. Very occasionally, if you had a full hand of symptoms, full hand of signs with negative markers, patients can have this condition and still need further treatment and workup for it. And I think just the one point I wanted to mention here, because obviously it came up in the case that I presented, is that immediately start high-dose corticosteroids when you suspect a patient has it, and then you go down the pathway of proving yes or no and working out a longer-term plan. The second group of conditions, or the second presentation when you may suspect vasculitis in your practice, is in this sort of this combination of small vessel vasculitis type symptoms or signs. And that really encompasses patients who are presenting with palpable purpura. It's such a giveaway, I suppose, which is why it's raised separate from the other organs, because the patient often presents with it and you can see it and feel it. And most people, when they see and feel it, they do think about vasculitis in the differential. And the other one that fits with this small vessel vasculitis is patients with progressive multi-system disease, where it's not otherwise explained by another disease pathology, noting that vasculitis is always going to be a very rare cause for any patient syndrome that comes into your office. So, palpable purpura. Let's talk about what's going on, because I think that this is a pretty confusing thing in many ways, because you'll see someone with a purpuric rash and you'll think, look, I saw that talk, does that mean they've got vasculitis? So these are a few tips to working out, is it significant or not? So what's going on? So let's think about the pathology here. So when you do a biopsy, the pathologist will report it as a leukocytoclastic vasculitis, which is really big words, and I'll explain what that means. But in essence, what's happening is the immune system's attacking the blood vessel wall, and that means that the blood vessel wall's getting injured, and it starts to leak. It leaks blood, and it leaks inflammatory debris, inflammatory cell debris. So on a biopsy, we see that the blood vessel wall has been damaged with this fibrinoid necrosis, as they call it. We see that there's neutrophil debris, and the sort of the fancy name for that is leukocytoclasia. So that's why it's called leukocytoclastic vasculitis, because there's neutrophil debris. And we see extravasated red blood cells, and that's critical because that's why it's non-blanching and it's red, because you've actually got red blood cells there. Compare that with a viral exanthem or another form of rash where you press on it and it blanches. In this case, it doesn't, because there's red blood cells there, and they're not going to go away when you push around on the skin. So going through some of those things in more detail, we see it usually in the dependent areas in the legs, sort of rising up to the buttocks, but much less on the arms. And why is that? It's because that the blood vessels are obviously being damaged by this immune attack, but the legs have got higher venous pressures, which means that they're both vulnerable because of the immune attack and also because of increased pressures. They're more likely to burst and release that inflammatory debris and the red cells. So that's why it's more likely, and we see it on the legs. It's purpuric because of the red cells that have extravasated. It's non-blanching because there's red cells there. And it's palpable, and that's the key kind of thing which separates it from other types of benign capillaritis. So, you may have some patients who have some venous hypertension, and they'll stand throughout the day or go on a long plane flight, and they'll get some purpuric, non-blanching rash on their legs. And in fact, it's called golfer's capillaritis. But the thing that separates that from palpable purpura or from leukocytoclastic vasculitis is the palpable nature of it, the fact that it's elevated and it's lumpy, and that's because there's inflammatory cells in the skin rather than just red cells that are extravasating. The other thing that's important is that it's painless. It's painless because these are very small dermal capillaries. And in fact, if someone's coming in with painful lesions with a mix of this, I'm start to get worried that I'm dealing with a more significant medium vessel vasculitis rather than a leukocytoclastic small vessel vasculitis. So even though the deeper skin's not involved and you're not getting ulcers and not getting pain, that doesn't mean that it's not a serious condition, or could be. Yes, it's not serious to the skin, but it's important because it may be a manifestation of systemic vasculitis, and it's the other organs that are going to get damaged by this insult. So when you see someone who has palpable purpura, the important thing is not to make a fancy diagnosis on the spot and say, I think it's IgA vasculitis or ANCA vasculitis. It's rather to first screen for the organs that are involved, because you've got to work out where are you going to investigate this patient. So how do I screen for organ involvement? So I do some basic blood tests, full blood count, kidney function, liver function, and inflammatory markers. Check the blood pressure. when the patient's there. You're checking that what the kidney function's like, and you need to do a urinalysis in all of these patients, whether or not you do a dipstick or a MCS and an albumin creatinine ratio. Check for it, because if there's hematuria or proteinuria, then we get worried that it's affecting the kidneys, and that, as I mentioned in the second case today, the kidneys can go off quite quickly. In terms of lungs, so we're asking about shortness of breath, hemoptysis, we're examining for crackles, and I do a chest x-ray in these sort of patients as a minimum, and obviously if there's concerning symptoms, a CT of the chest would be indicated. And then you're taking a history and exam. So this comes back, vasculitis is very much one of these syndromes where we need to go back to our clinical skills. We need to ask, is there painful neuropathy? Are there gut symptoms, eye symptoms, joints and sinuses? And you put together what organs you think are involved. And some pictures of the types of things that we may see. So over here, we've got a gentleman who's had pulmonary hemorrhage. In the middle, we've got a very aggressive palpable purpura with probably some deeper ischemic changes too. Here we're seeing some very aggressive ENT involvement in GPA, where we get this sort of necrotizing inflammation in the nose, which causes patients, and people will describe crust and blood from their nose. Every day I'm getting a lot of blood from my nose. Here we're seeing scleritis, here we're seeing a neuropathy, and here we're seeing hematuria. So going through those in a bit more detail, what are you going to say to patients when you suspect they may have small vessel vasculitis? You see their palpable purpura and you think, okay, what's my next step? Screen the organs. Ask them about, how have you been feeling? Have you had weight loss, night sweats? I saw a chap today with an anchor vasculitis who had pulmonary hemorrhage, but the 2 months before he'd had 10 kilograms of weight loss and night sweats and gradually worsening shortness of breath. Palpable purpura I've spoken about. They get arthritis. It's not erosive, but it's an inflammatory. It's overnight, early morning. My joints feel stiff. The neuropathy they get, you need to ask them about it, but I've been losing sensation on my feet and I've been getting tingling, and the typical one is a painful, and it's progressing. So it's not the type of neuropathy they've had for 3 years and it's maybe worsened over the past 18 months. It's the one that's getting worse. You know what? In the last 3 weeks, I've noticed this new progressive neuropathy. It can either be a symmetrical one, or textbook would be it just picks up individual nerves, mononeuritis multiplex. But it can be a progressive length-dependent neuropathy as well. We're asking about nasal discharge and crust. We're looking at the kidneys. We're asking about things in the lungs. And we're looking and asking about if they've had eye pain and new red eyes, because those are all manifestations or can be of vasculitis. We then take a history of potential triggers. So this is before we've sent all our blood tests and done skin biopsies. We're asking about new medications and supplements. We're asking about recreational drugs, and especially cocaine. The medication, the classic one is propylthiouracil, which is thankfully not used as much as it was before, and hydralazine, again, not used so much. Recent infections, parvovirus can precipitate a vasculitis and active malignancy. Speaking about skin biopsy, so when you do a skin biopsy in this sort of patient, what we're really trying to do is to confirm that there's leukocytoclastic vasculitis, and also to check if it's an IgA vasculitis, Henoch-Schönlein purpura. That's the other name for IgA vasculitis. You're trying to do 2 biopsies. Choose the newest lesions. They really need to be less than 48 hours old, ideally about 24 hours. You biopsy the edge, so you get some normal skin and some of the affected skin. And you're sending one in formalin, and the other biopsy you're going to send in saline soaked gauze, and that's the one that's going to do the immunofluorescence for IgA. Where to send these patients: if it's major organ, send them to emergency department. If you've screened them and it doesn't look like there's a major organ, you can send away the test and liaise with your specialist colleagues. So these are the sort of tests that we will ask for, and that I think that is quite appropriate for you guys to be, ordering, while you're waiting to get a sense of which way is going, provided there's not major organs involved, in which case, obviously, they should be seen in an emergency department for a more rapid workup. So, sending off anchor. If renal or lung, they'll probably be going to hospital, but we often send off glomerular basement membrane antibodies. We're thinking about RA, lupus, and Sjogren's syndrome when we're doing that connective tissue disease blood set that I've got there. We're thinking about infections, hepatitis and HIV, and occasionally if they've had a recent sore throat, strep serology, send off a cryoglobulin, looking for malignancy with a full blood count, sometimes an IEPG if you're worried about an MGUS. And then with everyone, as I mentioned before, your basic set of bloods, blood count, EUC, LFT, inflammatory markers, and urinalysis. The final presentation where you may suspect it, and this is my final slide, you may suspect vasculitis, but and it needs to be in the differential list, but it's very rarely due to vasculitis, are these episodes where we're getting recurrent atypical vascular events. So what's the one that we typically get sent and people get concerned about? We get concerned about skin, so we're talking about painful ischemic ulcers. We're thinking about renal infarcts, we're thinking about GI infarcts, and we're thinking about recurrent strokes with otherwise unidentifiable pathology. So vasculitis can cause this, and it's very reasonable to send off a vasculitis screen and certainly do those bloods and urinalysis that I said before, but always think for the more common causes. Think about infection and endocarditis. Think about thrombophilia. And in fact, that finger photo that I've got there, the top one is someone with antiphospholipid syndrome with digital ischemia. Think about, aggressive atherosclerosis, and also think about non-atherosclerotic vasculopathy. So there are conditions like fibromuscular dysplasia, which can be associated with renal infarcts and other atypical vascular events like dissections in the carotid arteries and in the carotid arteries and in the coronary arteries. And just because it came up when I was showing my slides earlier, there's also a photo of someone with Achenbach syndrome, that's in the bottom right. That's something where the blood vessel in the finger bursts, which is not a vasculitis, so just in case that has come up in your clinical practice. So I think we're going to do questions at the end, so I might hand back to Anita and Jess.
Great. Thank you, Tony, for such a fantastic intro to vasculitis. And I'll encourage anyone with questions, please put it in the Q&A and we'll address it at the end. So our next speaker is Professor Chanel Pei. He's also a nephrologist like myself, and he works at Royal Adelaide Hospital. Chanel's been very active in clinical research and particularly led efforts in Australia recruiting for one of the biggest international trials in vasculitis that really changed practice, and that was called the VASC study. He's going to outline an approach to ANCA-associated vasculitis. Thank you, Chanel.
Thank you very much, Jess, for your kind introduction, and thank you to Tony for setting the scene. I'm going to concentrate on ANCA-associated vasculitis. I'm going to share my screen now. Please let me know when you can see it.
We can see it, Chanel. You just need to do in the presentation. Beautiful. All
That's
good.
Great. Thank you. So the outline of my talk is as follows. What is it? Introduction to the disease. One slide on the pathogenesis, very briefly, a slide on ANCA as a biomarker, how good is it? Then I'll go on to common symptoms and disease manifestations, and I'll illustrate the disease with 3 short cases. There'll be one slide on treatment, and we'll finish on a conversation on what I think are the traps that had led to delayed diagnosis in my experience in the last 25 years. While ANCA-associated vasculitis, ANCA stands for anti-neutrophil cytoplasmic antibody, and from now on I'll abbreviate it as AAV, is a systemic inflammatory disease of unknown etiology. The disease is often involves multiple organs, but not always. The incidence is a rare disease, 20 to 40 new cases per million per year, depending on whose series you might refer to. And the prevalence is anywhere between 2 to 400. And the good news is that more of our patients with this disease are surviving longer, so the prevalence is probably perhaps a bit higher than that. Unfortunately, what the fact is fatal if untreated in majority cases. The morbidity is high despite treatment, especially in those with a severe diseases, disease manifestations like renal failure and lung disease, and especially in those diagnosed late, referred late, when they come with severe renal failure. And the morbidity comes not only from the disease itself, but unfortunately from the iatrogenic complications of strongly immunosuppressive medications, suppressive medications, which I'll come to towards the end. Nonetheless, despite this high morbidity, our patients from decade to decade have improved, the survival has improved substantially over the last 30 years, and that may be due to early recognition, better recognition, earlier recognition, early referral, perhaps, and perhaps better management. You may have heard of vagus granulomatosis. It is no longer referred to as WG. That is now called granulomatous polyangiitis. The other clinical, if you like, phenotype is called microscopic polyangiitis, or MPA. Increasingly, we are actually moving away from clinical phenotypes and going towards serotypes. So GPA often associates with the presence of an antibody to BR3, so we call it BR3 positive AAV, and MPA usually often goes with MPO. Not always. Sometimes this could go with this, and this could go with that. But generally, this goes with that, and that goes with that. So they correspond respectively with those items, as you can see. So for the rest of the talk, I will generally refer to this group of diseases as AAV. I have a brief one-page slide on pathogenesis. This is a complex field, and suffice to say that we really do not know the etiology, but the neutrophil is center stage in this disease. How come? We don't know. The theory goes as follows. There may be an infectious trigger, and that primes the neutrophil, and antigens such as proteinase 3 in green or myeloperoxidase in red may flip onto the surface. And if the patient happens to have an antibody to his or her own BR3 or MPO, the antibodies might bind to those antigens and activate neutrophils. And upon activation of neutrophils, they release lots of reactive oxygen species, which then damage endothelium lining, hence the vasculitis. Now, there are quite many problems with this hypothesis. Infection, well, what infection? We often look for it, but there is seldom obvious infectious trigger, or if there is, it is not easy to find. And the other major problem with this is, why is there breakdown of cell tolerance to your own neutrophils, components of your neutrophils? So that we can't answer. We know from mouse models that the anchor antibody is essential. That means you have to have it to have this disease, but it is not sufficient. So you have to have the anchor. That will be the first hit, but you may need a second hit, like an infection, query, or perhaps a third hit. So that's for the future, for researchers in this field to determine. So on to the next slide. Okay, thank you. A brief word on anchor. It stands for anti-neutrophil cytoplasmic antibody. And I would say from the outset that when used appropriately, anchor is an excellent biomarker, although not perfect. It's got a very high sensitivity. That means the vast majority of cases in which you have diagnosed this disease with confidence will have anchor antibody. I would say in excess of 95% in my experience in Adelaide. It is quite specific. That is to say, patients who don't have the disease are negative for this antibody. The negative predictive value is very high, and I'll come to that in a minute. And I'll make some comments at this point. If applied in the appropriate cohort of suspected cases, it performs very well. Now, to give you an example, if you were to order this test in everyone who's got arthritis, it is unlikely that you'll find many patients with a positive ANCA test. However, if you were to order this test in a patient or patients with arthritis and sinusitis and blood and protein in the urine and or raised serum creatinine, your sensitivity will go up, definitely go up. So when applied, asked for in the appropriate cohort of cases, it is a very good test. Equally importantly, a negative test is also quite useful in the sense that a negative test would argue against the diagnosis. So it's got a very high negative predictive value. That said, there are sometimes false positives, and Dr. Samo had referred to, for example, 10% of cases of infective endocarditis of the heart valve will have a positive ANCA, and that can be a trap. So beware of false positives. Fourthly, in some patients, though not all, the antibody titer correlates quite well with disease activity. So with time and with treatment, the antibody titer comes down, though not in all cases. And conversely, a patient who had a low level for some time after treatment, and suddenly within a few weeks or a few months, there is a rise in antibody titer that can precede the next flare, so better watch out. Again, not always, but in some cases. But overall, as far as biomarkers are concerned, I would rate the ANCA biomarker as an excellent biomarker, certainly compared to the time in the early 80s when we didn't have this biomarker to mark for this disease. So on to clinical features. Slightly more males than females. This is not a disease of the very young or patients in their 30s and 40s. Certainly, we have had patients in their 30s and patients in their 80s and that I've seen, but the median age that should have been median and not mean age is about 63. Mostly seen in Caucasians. Comparatively more rare in other racial groups. You do see it in Chinese, Japanese, in other racial groups, but in Australia, we see it predominantly in Caucasians. Now, in bold, I have mapped out the important features to think about, which are common to this entity. Lethargy is a very dominant feature. Weight loss of 5 to 10 kilograms, fleeting joint pains or just aches and pains in joints and muscles. And it is important to keep in mind, have an idea of the time scale of presentations. This is not a disease that will, lead to death within a few days, nothing like that. It runs usually over at least 4 to 6 weeks, 2 months. I've had patients who have said, oh, yes, starting from 13 months ago, I started feeling unwell. So it is not uncommon to hear, look, I have been unwell for more than just 6 weeks, maybe a few months, and I've been to my GP several times, and finally it was when the serum creatinine went through the roof that we suspected this. So there would have been several opportunities to suspect this illness in the last few months. Now, anemia chronic disease is almost ubiquitous. High CRP and ESR are not differentiating inflammatory results, but they are nonetheless often high. And I put next to asterisk next to renal and pulmonary because they are life-threatening organ manifestation. As far as the kidneys are concerned, glomerulonephritis will occur in about 75 to 80% of cases. The longer you follow them, the more you see. The problem, though, is that glomerulonephritis as a disease manifestation has no symptoms. That the patient doesn't come and say, I've got blood-stained urine. Microscopic imagery that you can actually visualize with a human eye without microscope is very rare. And detection of microscopic hematuria and proteinuria by dipstick in your office offers the only chance of earlier detection or suspicion before the onset of rapidly progressive decline in renal function. And renal failure, especially severe renal failure, is important because it correlates with high morbidity and mortalities despite modern treatment, unfortunately. In the lungs, cough, shortness of breath, hemoptysis, lung hemorrhage, lung nodules, and I'll show you pictures of those, and rarely interstitial lung fibrosis. And there may be other telltale signs, not in every patient, but in some patients. The sinuses are often involved in GPA, hearing loss, obstruction of the eustachian tube, fluid in the sterile media or otitis media. Eventually, in some patients, though not all, saddle nose due to destruction of the cartilaginous component of the nose and involvement of the vocal cord, stridor, tracheostenosis, and sometimes disturbance of the vestibular organs of the cochlear apparatus, loss of smell, and gingivitis. And skin, Tony has mentioned, non-painful, non-itchy, purpuric rash, biopsies showing leukocytic vasculitis, ulcers are quite rare. Episcleritis in the eyes, blocked tear ducts, and then you have rarer manifestation like mononeuritis or peripheral neuropathy or isolated cranial nerve involvement and muscle claudication like jaw muscle pain on chewing food. So to summarize, lethargy, weight loss, profound weight loss of 5 to 8 to 10 kilograms, fleeting joint pains, aches and pains in joints and muscles. Keep in mind the time scale is anywhere between 6 weeks to 6 months in that zone. And a collage of photographs to demonstrate what I have talked about. Top left, assuming you can see my cursor, is a destruction, wanton destruction of this poor patient's sinuses. You can see the septum has been totally destroyed. There's destruction of the turbinates, nasal turbinates, destruction of maxillary sinuses. This poor young woman has developed a saddle nose. She's Cushingnoid. She's got a double chin, and if you were say to ask her to take a deep breath, she'll say, breathe out from stridor. And she may have to have a grommet and a hearing aid behind her lock of hair. And this one is episcleritis. And in her x-rays, you may see pulmonary granules, nodules, I should say. And if you look carefully, there's cavitation. And in 1937, when Dr. Friedrich Wegener described this syndrome, it was hard to tell apart. The first suspect diagnosis was TB, but they could not find MTB, despite attempts. So this, and the name actually bore his names of Wegener's granulomatous, but since then we moved away from that name to GPA. And typically, a patient with sinusitis, eye involvement, and pulmonary nodules with cavitation, if they were to have this disease, they will have a pattern of antibody staining of third-party neutrophils, showing that there is an antibody in their serum that binds to something in the cytoplasm of third-party neutrophil, typically targeted towards BR3. Now, in this different patient, this is a young 35-year-old patient who presented with a 6 weeks history of feeling vaguely unwell and eventually hemoptysis, and you can see bilateral alveolar hemorrhage before treatment. And this was a repeat X-ray taken exactly a month later, showing clearance of hemoptysis. Moving to the right panel, you can see non-itchy, non-painful, non-blanching purpuric on the ventral surface of my patient's right foot before treatment. And rarely, if left very late, the lesions may coalesce and form painful ulcers, but there's a very advanced sign. late sign. So on the bottom left is indeed a patient with severe glomerulonephritis, and you can see formation of a crescent. A crescent is a proliferation of the Bowman's capsules, cells lining the Bowman's capsules. They're very large cells, and they compress what remains of the surviving glomerula. And you can see that not every glom is involved. This is partly involved, this is terribly involved, this is probably not involved. So it's a focal process, not every glom is involved. And these are called crescents, is a sign of severe glomerulonephritis. Now, at this point, it is important to spend a minute or so on this slide here, because this graph relationship graph tells the relationship of what happens to creatinine when your GFR drop. Eventually, in summary, it is an inversely proportional relationship. Yes, when your GFR drops, eventually your serum creatinine will rise. But the point to note is that you can lose something like 50 to 60% of GFR, and yet your serum creatinine hardly rises above 1. This is in milligram per deciliter, North American units. So that is about 90 micromoles per liter. So you can lose a whole chunk of 50 to 60% of GFR, and yet the serum creatinine barely rises above normal range. So, and yet if you lose more GFR after that, then your serum creatinine starts to rise really rapidly. But by then it is often too late. So the only way to pick up this, suspect this disease early, if you were to do, is simply to do a dipstick in your clinic on the spot, and you will see discovery of blood here and protein. And if you have this and that and that, and blood and protein, you know for a fact that almost know for a fact that this patient has glomerulonephritis. We'll come to that in a minute. Now I'll run through 3 cases, and I'm having difficulty advancing. There we go. So the first case is, these are real cases that I've seen in the last 15 years. Mrs. GR, 68-year-old, no relevant past history. And interesting, both she and her husband went for a cruise, and they had a wonderful time, but came down with what felt like an upper respiratory tract infection. Take note of the date, September 2011. He improved, but she got worse over the next 4 months. And what happened? Well, she developed severe sinusitis. She's never had this before. Then one ear went off, then the other. Then she went to see a ENT surgeon who found that it was a ruptured right tympanic membrane, profound weight loss, peripheral neuropathy, extremely debilitated. And by the time we saw her 4 months later, she already had developed acidosis. And finally, it wasn't until her serum creatinine was evidently very abnormally high that she was referred almost 4 months later. Now, as you can see, and I apologize for this series of numbers, but they are not there to spook you, but simply you can see that there was a blood test in December, 3 months after she had first symptoms, and her serum creatinine was 59. Now, had the referring medical officer done a urine test, he or she would have found blood and protein, and had she been referred then, we may have avoided that. And you will recall me saying that if the patient comes in with renal failure, then the prognosis is not as good. That goes without saying. And this patient, fortunately, is still alive 15 years, 10 years later, 11 years later. I saw her last week, and she's been left with a serum creatinine about 160 or so. And in her, this was her biopsy, you can see a big crescent, and in fact, it's actually ruptured the Bowman's capsule because disease was so active. The next slide. Shows PR3, and you can see with time and treatment, the PR3 titer went down. It stayed low for some years. And this is what I had mentioned before. Sometimes a sudden rise in the anchor when tracked over time from every 3 months when we see her. In fact, there was a sudden rise, and in fact, that preceded the next flare of disease. The good news is that she's now anchor negative, and she's still alive and well, though with significant renal impairment. The next case is quite telling as well. He was 69-year-old. He was a 69-year-old truck driver. His only past history was that of hypertension, and his history was that of being unwell for 2 months. And he started off as a hearing loss. In fact, he went to see an ENT surgeon who inserted grommets into both ears. And then he couldn't drive. He had to stop working because he couldn't walk on the straight line because there was disturbance of his vestibular apparatus, leading to a sense of loss of balance. Among that, he lost a lot of weight. There were some night sweats at the end, and then development, so finally, of macroscopic hematuria, which heralded the development of acute renal failure. You can see here when he went to see his GP with this was actually his urine that he brought in when he passed into his urinal when I saw him in ED 2 years ago. Now, unfortunately, no one had done a urine test before then. You know, he had been unwell for about 2 months before that, and had one been done, you would have found blood and protein easily on the dipstick before he had developed this macroscopic hematuria. He was treated with a course of antibiotic. The creatinine continued to rise. He was referred from a country hospital to a regional hospital, and it wasn't, 2 weeks later a week later that he came to our attention. By then it was too late. We had to put him on dialysis, and unfortunately he has not done well since. The last case, a 77-year-old man, past history of hypertension, and he had had a baseline of about 140 serum creatinine, we believe, from many years of hypertension. And again, very typical history, several months history of aches and pains, weight loss, lethargy. And in fact, he had 3 weeks history of increasing shortness of breath and hemoptysis, and went to see a chest physician who performed bronchoscopies on 2 occasions. And, this chest physician watched his serum creatinine rise from 180 to 240 to 300 over the past month before he gave us a call. And by then he had had severe renal failure. He was ANCA positive. It was MPO positive. It improved with time. Yes, and his renal function improved with time again, but he has been left with significant renal failure. And this is his chest X-ray showing bilateral lung hemorrhage on the background of emphysema from smoking. So one slide on the principles of treatment. Not to treat the patient is not possible. We do and occasionally encounter that in the very elderly, but generally the situation compels treatment, because if untreated, the mortality is almost certain. The aim of the management is to induce clinical remission with immunosuppressive medications. And once a clinical remission has been achieved, generally within 3 or 6 months of starting treatment, then we will taper down the intensity of immunosuppression to maintain remission. And you have to run the maintenance treatment for often several years before even thinking about backing off a bit. And the standard of care treatment here, or indeed around the world, is high-dose oral prednisolone, typically around 50 milligram a day. But that by itself is not enough when you have vital organ involvement. So you have to combine it with either cyclophosphamide or rituximab. And rituximab is a monoclonal antibody to CD20B, CD20 antigen, which is expressed by peripheral B cells. At this point in time, I would add that prophylaxis against pneumocystis cerevisiae, or what we used to call pneumocystis carinii, fungal infection, is very important. I still remember losing patients when in the late 80s, when we did not do this routinely. Most patients can tolerate trimethoprim sulfamethoxazole. And once remission has been achieved, we maintain remission with low-dose prednisolone and in combination with either azathioprine, or mycophenolate mofetil in those who cannot tolerate azathioprine. Intolerance, in fact, hypersensitivity reaction to azathioprine occurs in about 8% of our patients with this disease. Or else we can use a rituximab to maintain the patient in remission. That said, in the COVID age, any form of immunization is troublesome, but we cannot not treat these patients, so we do our best. In very severe cases, plasma exchange can be considered. Now, there are many outstanding concerns, and you would fully appreciate that these are very potent immunosuppressive medications. So they have potent effects as well as potentially potent side effects, and that said is mostly to do with infections, so either opportunistic or non-opportunistic. And there is increasing recognition that some of the infectious complications of treatment, it is due to prednisolone, especially high doses of prednisolone. And there is a move in the past few years, and I would say increasingly so in the next decade, of where investigators like will see whether we can reduce the burden of prednisolone by using a prednisolone sparing agent. It will be wonderful if we can get away from prednisolone altogether, but for the moment, we are still stuck with some prednisolone. Of course, the other question that hangs about is how long to maintain treatment. This is not a disease where you can stop maintenance treatment after a few months, because almost certainly the damn disease will come back. So often we maintain the patient on low-dose prednisolone in combination with one of those agents. I'm happy to answer questions in regards immunosuppressive treatment or their complications. We have time later on. That said, I'm coming to the last slide. And the question is, well, can I make a difference? Yes, you definitely can make a difference to patient care by suspecting this possibility before the onset of severe renal disease or lung disease. When I look back across my experience in the last 25 years or so, the cases that have done poorly or died were often those cases who have been referred late. That's true. Some cases will, die irrespective of whether they're referred early or late because they had such severe disease. But it is true, I think, in general, to say the earlier the suspected disease, the earlier the diagnosis, the better the patient will do. So beware of common features such as lethargy, weight loss, aches and pains in joints and muscles. Keep in mind the time scale of the disease. This is not a disease that occurs in 2 days or even 1 week. It often has run for weeks or months. And there are often telltale features, but not always, telltale features like sinusitis, episcleritis, cough, shortness of breath, of course, hemoptysis, lung involvement. Keep in mind that glomerulonephritis is a silent disease until quite late. And typically, when you take the history, the patient said, yes, I had to go back many times, several times, repeatedly. So it's a recurrent presentation. So you have that you prick your ear, say something's going on. I don't know what's going on, but something's going on. Let's keep an open mind. Beware of the limitations of using serum creatinine too slavishly to track renal function. And I come back to this curve, and this time I have marked it amber and red to denote that as GFR drops in time, initially you can lose 50 to 60% of GFR, but the serum creatinine remains less than 100. That said, if there's a deteriorating trend, one day the creatinine may be 65, a week later it may be 85, and then the next time when you see the patient is now 120, well, there's something going on. By the time the patient's serum creatinine has gone past 100, the patient is in trouble because the patient has lost 50% or more of GFR. And in this area, any further drop in GFR will translate to big jumps in serum creatinine, so much so that it's often a very advanced disease and often too late. Now, how do we pick it up early on, suspect that there's a GN? Well, it's easy. And this test takes 5 seconds to do. Please do a dipstick on the spot in your clinic. In 25 years of practice, I've never sent a microurine to the lab. I've always dipsticked the urine. Blood and protein, I would go as far as saying that if there's no blood or protein, your patient does not have GN, full stop. If there is a blood and protein, well, it strongly suggests that there's GN, so it may be consistent with this disease. The anchor test is a very good test if used appropriately. It's got a very high negative predictor value. That is to say, if the test is negative, it is unlikely that your patient has the disease. And if applied to an appropriate patient cohort with arthritis, sinusitis, blood and protein in urine, maybe kidney failure, it has a very good sensitivity. And lastly, please do not hesitate to ask. I can say for myself and my unit in Adelaide that my renal registrar or myself, if we were on call, would be very happy to take your call to discuss a case that you suspect may have this disease or some other form of GN. And my last statement is that you can definitely make a difference by helping us make an earlier diagnosis. So at that point, I'm going to stop and pass it back to Jess. Thank you for listening. Happy to take questions later on. I'll stop share now.
Thank you, Chenal, for a fantastic talk. And I'll reiterate what Chenal just said about, if you're very worried that a patient has this disease, time is kidney function, and certainly getting onto our renal registrars or consultants, we'd be more than happy. Our next speaker is Professor Catherine Hill. She's also based in South Australia at both the Queen Elizabeth and Royal Adelaide Hospitals, and she's a clinical rheumatologist, epidemiologist, and expert in evidence-based healthcare. She happens to be the immediate past president of the Australian Rheumatology Association, and she's an expert in giant cell arteritis, and her presentation will outline an approach to GCA. Thank you, Catherine.
Thanks so much, Jess. And thanks everyone for coming tonight. I know it's the end of a very long day, so we really appreciate your time and to talk about some diseases that we're all passionate about. These are my disclosures. So I'm going to just briefly talk about, cover what is GCA and who gets it, and some of the symptoms and signs, some of the mimics, treatment, and some take-home messages. So it is a conundrum, and I think Chenal also referred to that with ANCHOR AAV as well, because it's the commonest vasculitis of the elderly, but it remains rare, but untreated it can cause irreversible blindness and stroke. There's often some diagnostic uncertainty that I'll discuss. We do have effective treatment with glucocorticoids, but with way too much morbidity related to that. But probably since you were medical students and heard a lot about this illness, there has been some progress. So as Tony mentioned, it's a medium to large vessel vasculitis, which affects predominantly the extracranial vessels like the temporal arteries. But also prominently the thoracic and arch aorta and subclavian vessels. And we're increasingly recognising this large vessel involvement with improved imaging. It's really a disease of older age, so rarely diagnosed under the age of 50, and really the median age in South Australia is about 78. But it is important to remember that the prevalence increases with each decade of life. 60% of patients are female, and there is a Caucasian predominance, predominantly those from a North European heritage. And if we look at this global map, you'll see that the incidence per 100,000 is really much higher in the Scandinavian countries, and also in those countries where people have migrated from those countries, such as Minnesota in North America, and we have a much lower incidence in South Australia. It's about 4 per 100,000, and that's of over 50. So that's in that elderly, and actually quite a bit higher in New Zealand, mainly because they have a lot more Scottish background, so that more Northern European background. So Tony talked about the 5 cardinal symptoms. And I'm going to go through these one by one because I think it's important to, recognise some of the issues and the prevalence of these. So So about 70% of patients present with a new headache or scalp tenderness. And I think it's important to recognise that this is a new or an altered headache. And most commonly, that'll be a unilateral or bilateral temporal headache, but can be more widespread. And the lovely case that Tony presented, actually, that patient had some parietal and some occipital pain as well. But classically, it's a temporal headache. It often begins a little intermittently, but as the disease course, it becomes more constant and will worsen. Scalp tenderness is often felt when patients are combing or touching their hair. And the things to look for are tenderness or swelling of the temporal arteries and this scalp tenderness when you press. About 50% of patients describe jaw claudication, and that's pain on chewing, which eases when they stop chewing, often worse with hard foods. I have a patient this morning telling me how hard it was eating a schnitzel. And the pain is often in the masseter region and not classically in the TMJ, but some patients do describe it in that area as well. Also, patients also complain sometimes of pain on swallowing, and this is probably related to tongue claudication. The reason why we're so interested is that this is actually highly correlated with positive temporal artery biopsy and is quite a specific symptom for temporal arteritis. Probably 25 to 30% of patients present with a visual disturbance. Now, that classically is a painful loss of vision, either binocular or monocular, usually monocular. But it's often preceded by some transient visual loss or amaurosis fugax. And so that's the very momentary visual loss. Sometimes they'll talk about a blind going down through one of their eyes. But the other visual symptoms also include episodes of diplopia, which also Tony described. Important to remember that 85% of visual loss is caused by an anterior ischemic optic neuropathy. But it's also important to remember that AION is, in the majority of cases, actually not caused by GCA. Other things that they can get is a posterior ischemic optic neuropathy or a central retinal vein occlusion. So sometimes a pale disc can be seen on fundoscopy, but it may be normal. And also important to check those extraocular eye movements. The reason why we're so concerned about visual disturbance is that once established, visual loss is rarely reversible. So untreated, so if you have a patient with monocular visual loss and that person doesn't get treated immediately with glucocorticoids, 25 to 50% will lose sight in their unaffected eye within the next week. So you can really go from a patient who's lost vision in one eye to complete blindness, and which means almost always in these patients needing to go into a nursing home. Steroid initiation markedly reduces the risk of further deterioration, but will not improve established visual loss. So we talk about rule of 4%. So starting steroids reduces the risk of further visual loss to about 4%, but the chance of recovering vision is approximately 4%. That said, sometimes patients will do get some return of their vision, but often not back to normal. And that's why starting prednisolone prior to the biopsy is key to saving sight. About half the patients will have PMR type symptoms, so classically the aching and stiffness of the shoulder and hip girdle. And conversely, GCA affects approximately 10% of patients with PMR, either at onset or later in the disease course. And I've got a number of patients in my practice who initially were treated for PMR and then some months or years down the track actually developed GCA. So it's always very important to remind patients of GCA symptoms and ask them to present early if they do develop any other GCA symptoms such as headache or jaw claudication or visual impairment. Stroke is rare, but it is most commonly in the occipital lobe infarction resulting from a lesion in the vertebrobasilar circulation, and that leads to a different type of visual impairment, which is a homonymous hemianopia, and occasionally even complete blindness if they get bilateral occipital lobe infarctions, but it does rarely affect the intracerebral vessels. Constitutional symptoms are interesting, fever, weight loss, sometimes some sweats or fatigue. And about 10% of patients may present with constitutional symptoms with elevated inflammatory markers alone. And they actually may present as a PUO. In fact, GCA is one of the common causes of PUO in the elderly, accounting for about 1 in 6. But really, constitutional symptoms alone, particularly fever, really need to first exclude, obviously, infection and malignancy. These patients, in my experience, often get admitted to hospital for their PUO and then require further investigations. As I mentioned before, we're increasingly recognising large vessel involvement. Most commonly affected are the thoracic aorta, subclavian, axillary and carotid. So some of these patients may describe limb claudication and asymmetrical pulses and asymmetrical blood pressure readings in the upper limbs. As shown there, it's really most commonly the thoracic, subclavian, axillary, but rarely we see the iliac and femoral and abdominal aorta affected. It's sometimes upper limb claudication and PMR symptoms need a careful history to delineate those. So after you've found that the history and you're suspicious, obviously initial lab testing should include the full blood count, ESR and CRP. And as mentioned, 96% of patients will have elevated inflammatory markers. We're really looking for an ESR over 50 or CRP over 20 and a platelet count over 300. We've done some work on, we've got a GCA registry in South Australia, and we've done some work looking at the utility of ESR, CRP and platelets, and each of them are independently predictive. I'm always a little suspicious of an ESR, an isolated ESR rise with no CRP and no platelet rise. You'll see there that that combination is not particularly predictive of GCA. If I see that, I'd really like to have a look back and see whether the patients had any previous ESRs, because it may be another cause of their headache and they've got a monoclonal gammopathy of unknown significance or something like that. However, if patients have all three positive, the chance of them having GCA is much higher too. Sadly, we don't have a biomarker for GCA, unlike in AAV. So I wanted to go back to the case that Tony presented. This lady had the headache, the scalp tenderness and the night sweats, and then went on to have jaw claudication, the transient diplopia, and then the monocular visual disturbance. And so really fits all the criteria for GCA, and then especially with those very high inflammatory markers and the high platelets. And although there is some slight sphenoid sinus congestion, really the working diagnosis is GCA, and the patient really needs prednisolone immediately. For patients who've got visual loss, the best treatment is intravenous steroid and immediate eye review. So those patients need to go directly to ED. For a patient who you suspect has GCA, I would really highly recommend you call your local rheumatologist or the rheumatology registrar at the hospital. So this is really an emergency because we want to stop blindness and stroke. So 50 milligrams for patients with no visual loss, and IV methylpred for those with, and reach out to colleagues. So this is what we're talking about: initiation, urgent referral to eyes if they've got visual disturbance. But where do we go with diagnosis? So because of the risk of visual loss, we usually treat and then do some diagnostic testing. And the diagnostic testing that we have available has actually increased dramatically in the last few years. Previously, we really just had temporal artery biopsy, which is highly specific but has a lower sensitivity. And because of the skip lesions seen in giant cell arteritis, and you are only taking a small piece of artery, the sensitivity can be low, and there's this concept of biopsy negative GCA. It does have the advantage of being positive for up to 2 weeks after steroid initiation, and probably in some patients even longer than that. So you can treat with steroids, and even if you can't get the biopsy immediately. Who should be doing biopsies? Well, I think there's a range of surgeons who are really competent at temporal artery biopsies, and ophthalmologists will often do their own if the patient has visual disturbance, vascular or plastic surgeons or general surgeons. At my hospital, the plastic surgeons perform the temporal artery biopsies, but it will be different in different services. If we turn to imaging, over the last few years, temporal artery ultrasound has really taken off. We see a classical halo sign in the temporal artery. There is some operator dependencies with it, but it does have similar sensitivity and specificity to a TAB and can be ordered through your local private radiology firm. I would also consider asking about for carotid and axillary ultrasounds as well. If a patient has amaurosis fugax, you really should be doing a carotid ultrasound anyway. So I would often order those at the same time. Increasingly, we're doing MRIs of the scalp artery and CT angiography. MRI of the scalp artery does need special settings, and so needs to be really clearly that that's what you're asking for. I think in many cases, this kind of imaging will be something that the specialists will often be asking for. PET scans can be really helpful, particularly in those with PUOs and large vessel involvement. There are some very specialised PET scanners can also look at the temporal artery as well. Those are not so readily available. It's important to remember, though, the imaging, each of these imaging modalities does have reduced sensitivity after a shorter amount of time on steroids. So getting them to these diagnostic procedures as quickly as possible after starting steroids is important. So I think a careful history and examination is really important, the inflammatory markers, the imaging, and consider other imaging to exclude other diagnoses if you're really still not sure. Ophthalmology input's really key, and a temporal artery biopsy is still the gold standard, but if you've got a clear diagnosis with one of the imaging, it may not be required. I just wanted to touch on some of the common GCA mimics. And I think if you suspect GCA, they've got very high inflammatory markers. Still, obviously we need to treat because we want to save sight, but I think it's also important to remember some of the other things that can mimic it. Sinusitis is one of the most common ones that we would see. A CT scan, including the sinuses in the brain. Herpes zoster may mimic GCA before the skin lesions appear. TMJ dysfunction causing pain localizing to the temples, but can also be associated with some scalp tenderness and some pain on chewing. But typically no raised inflammatory markers. and trigeminal neuralgia, but it's usually paroxysmal, and patients have often had episodes before, and the other headache syndromes as well, and other causes of acute visual loss. So steroids remain the backbone of therapy in GCA. We use high dose oral prednisolone and IV in visual loss, and we start to taper the prednisolone once inflammatory markers have normalised, symptoms resolved, and that's usually around the 4-week mark. We generally do a 12-month taper, unless we're going to use steroid-sparing agents, and then it's often a 6-month taper. But when we're using high-dose glucocorticoids, I routinely give them some PPI for their reflux, PJP prophylaxis, as mentioned by Chinao, osteoporosis prophylaxis, and make sure they're up to date with their vaccinations. But glucocorticoid side effects are so common in this group of patients. Although we aim to get them off steroids within 12 months, we often don't succeed with that. And that's because relapses are really common in this disease in about 50 to 75% of patients. So this is the data from our state where mean duration of steroid use was 4.5 years. This was actually before we started using some steroid sparing, and that's probably why. But you can see 90% of patients had glucocorticoid side effects. So educating patients before we start high-dose steroids is really important. The ARA has a great medication leaflet on prednisolone, which I go through with patients. I discuss the important side effects around blood pressure, BSLs, sleep and mood disturbances, and skin and bone fragility and infection risks, and also the need not to stop suddenly, and monitoring, obviously, the blood sugars, their blood pressure, their BMD, and their mood. I find in these elderly patients, the mood disturbance can be really difficult, and ranging from, depressed, high, aggression, tremor. And the skin fragility and the easy bruising is something that patients really dislike and do mention a lot. We have a couple of drugs for reducing glucocorticoid burden. Methotrexate has been used for many years, although the data is not very conclusive. But tocilizumab is one of the new biologic agents. It's the first biologic agent for GCA. It's PBS funded for new patients and relapsed patients, and it's especially useful for those with at high risk of glucocorticoid side effects, such as those with pre-existing diabetes psychosis. You have to have GCA symptoms, high inflammatory markers, and positive imaging or biopsy. It's given as a weekly or fortnightly subcut injection with a duration of 12 months, and has to be prescribed by a rheumatologist or a neurologist. It's been shown to reduce relapse and reduce steroid burden by allowing a faster glucocorticoid wean. So it really has a place in it. It does have some side effects, increased risk of infection, neutropenia, increased cholesterol, and rarely bowel perforation. So how do we monitor symptoms? Inflammatory markers are obviously helpful. We obviously need to monitor for glucocorticoid side effects, and unfortunately we haven't really been able to use imaging. There's not good data as yet, but we're hopeful. Interestingly, treated GCA doesn't have an effect on mortality, but obviously a large effect on morbidity. There is a twofold increase in risk of aortic aneurysms, and they tend to be thoracic aneurysms. They have the standard risk factors of males, smoking, hypertension, and diabetes. And as yet, we don't have any consensus on long-term monitoring for these. So to end, I just wanted to say that this is a rheumatological emergency, and there's not many of those due to the risk of blindness and stroke. But if you think of it, the possibilities, please check their inflammatory markers, and if those are elevated, or either commence prednisolone and call your local rheumatologist or rheumatology registrar at the public hospital. We are so happy to get calls about these patients, because really early appropriate care is the best thing for the patients. But it is important to remember this is a high impact of this illness on people, and this shouldn't be underestimated. I have GCA patients are often distressed by the combination of this serious unexpected illness and high dose glucocorticoids. And finally, I wanted to let you know about some places where you can get information for your patients. The ARA at rheumatology.org.au has great medication information sheets about prednisolone, but also the other immunosuppressants. And Arthritis Australia has information sheets about GCA, and also some great patient videos with clinicians who treat GCA, but also some patients who've actually experienced this severe illness. Thank you, and thanks so much for your attention, and happy to take questions.
Thank you, Catherine, for that fantastic talk. So I'm going to hand over to Anita now. I'm going to get all our speakers to put their cameras and microphones on, and Anita's going to run some questions. We have gone a little bit over time, so bear with us. If we don't get to all the questions, we'll endeavour to answer them offline later.
Thanks, Jessica, and thanks everyone. That was such a good presentation, such a great topic, such a mysterious topic in many ways for GPs, where we will expect to see some of these conditions once or twice in a lifetime. However, there is giant cell arteritis, and we know we're going to see that often. So I'm going to start with that because I'm going to pool some of the questions together about giant cell arteritis, and I'll leave it open to the panelists to answer. In general practice, we're the masters of uncertainty. So people come in early with things that may or may not be what we fear and worry about over time. And so some of the questions from the audience is, well, what do I do if I have a patient who's in the appropriate age group with perhaps only one of the 5 or 2 of the 5 symptoms, and a kind of maybe slightly elevating inflammatory markers? Do I treat them? Can I make the diagnosis? And how hard do I have to chase down a formal diagnosis with things like imaging and biopsies? Because we're often seeing things early and still semi-undifferentiated. So very keen for your advice on that.
Tony, do you want to? No.
You want to go first, and then I can.
Yeah. So I guess that in the patient who has maybe the headache and maybe a few constitutional symptoms and maybe a ESR that's 50 and a CRP that's 15 or something, I think that's the case where I think there's 2 ways you can go there. You can have a think about whether there's any other things that might be causing this. And I think sometimes when people think of the diagnosis of GCA, they kind of lose all of the other potential differentials. So that's one thing. Have a think about whether there's any other causes. 2, consider ringing your local rheumatologist. Tony Samuel, he's on the phone if you live in Sydney, or I'm very happy to take calls. Or this is another area where maybe some more simple imaging that you can do, such as a CT and a temporal artery ultrasound, which you could order through your local radiology would be helpful. You asked me the question earlier about when do these inflammatory markers rise, and there's because we only know what happens when the patients are diagnosed, we don't have good data about their rise in the ESR, but I have seen patients myself who've come in with fairly low inflammatory markers, and then when I've checked them again, even 12 or 24 hours later, they've risen quite dramatically, and then we've started steroids. So I think seeking advice, considering some imaging, and getting the patient back, and also because vision disturbance is the thing that we most worry about, if they have any sort of visual disturbance, telling them to get down to ED if that happens.
And I think that's one of the answers. That's one of the questions here. So what if I've got some vision symptoms and everything else is a little bit sort of nondescript? And I think that one of the key messages here is the vision disturbance is absolutely the emergency symptom.
Absolutely. And you need to get them down to the ED, seen by an ophthalmologist.
Yeah, so absolutely. And remember, this is a particular demographic, but absolutely, I mean, vision loss is an emergency, but with this group, absolutely.
Do you have anything else to add, Tony?
I think it's a really tricky situation, and I hope you don't have to do it too often, because I find those cases difficult, and I think pick up the phone. I think you never get into trouble, if you tell me someone's got a new headache and there's, ESR is 50 or the CRP is 20, and they're not feeling so well. I think that sort of patient does warrant some treatment, and to start treating and to then prove it. And I think if there's questions, I think, give us a call. There was a someone I saw on Monday who's, 70-year-old guy who's got some new discomfort in the temporal regions. He's had it for a week. He was a bit concerned. He's a doctor himself. And I suggested he get some inflammatory markers. I saw him that afternoon. The headache was pretty unconvincing. His inflammatory markers were normal, and we didn't do anything. But I think you do need to take those steps. And if you've got enough concern, don't let it rest. Call one of us up, or get going with the diagnostic pathway. The one thing I do want to raise is in terms of imaging. So it's very, very operator dependent. And there are a couple of centres in Sydney that I really wholeheartedly trust. And there are a lot of centres where if they just do one a month or so, it can be a bit of a coin toss. So, I think that speak to your local rheumatologist about, if you're going to use imaging, where do they suggest? And they might suggest nowhere. They might say, you know what, I don't trust anywhere, do a biopsy. Or if someone was to call me, I might suggest one or two places in Sydney, but it really is a very specialised imaging modality. So ask where to send before you just go and send it. I don't know if Catherine, if you feel the same.
Yeah, we're lucky enough to have a vascular surgeon who does some of the ultrasounds at our place, and I also have a rheumatologist colleague who does them. But yeah, I feel the same way. And one of the places is actually reasonably good, but it is very operator dependent.
I just want to turn now also to the dreaded ANCA-associated vasculitis. Now, I remember as a medical student, then as an intern, fearing this disease, and I may have over-ordered a few ANCAs early in my career, thinking it was hiding on every corner. It doesn't. However, it is a catastrophe. So I do want to ask the question early on. So this is general practice. It's early, it's undifferentiated. We are the specialty of it could be anything. Somebody comes in fatigued with all sorts of interesting symptoms. If I do an ANCA once and it's early in the time course of this disease, does that answer my question? Or is there a lag between presentation and then the development of these antibodies? And do I need to keep going back to answering the question? And I'm going to say, put your answers about the urine aside, because I do want to explore the vital importance of urine. I just want to talk about the reliability of ANCA, particularly early, when we're using them in the community.
Jess, are you happy for me to take the question?
Go for it.
That's an important question. And the answer is, even if done early, it will be positive if it is in fact a disease. That is to say, it will not simmer from negative to high within a few weeks. It starts high and it stays high positive. If it is negative, then it is very unlikely the patient has the disease, even if detected to be determined to be negative early on. This is a very interesting question because it borders on the next question, which is how long has the patient had ANCA in the bloodstream? And we know that from a study done in the American Veterans Affairs, because in that country, recruits are encouraged to bank their serum every year. And when they finally have a cohort of patients and they ask question, how long have you had the serum? And they go into the deep freezer and pull out samples from 1 year, 2 years, or even 5 years ago. And guess what? They were all positive for a long time. So it begs the question, why have they had the disease now and not 5 years ago? So in short, the answer is, if it is going to be positive, you will find it early on. If it is negative at the start, most unlikely that the patient will have ANCA. I hope that answers your question.
It does. And I know we've only got 4 precious minutes. Now, urine. It's so important. Telly O'Connor says in the urology and nephrology section, laments that we don't do enough urine analysis in medicine and we miss things. I have a deep fear of sending an EGFR out into the world without an ACR. But you're telling us don't send a renal function out into the world without an MSU, or at least a dipstick. So what are your comments? Because we see acute illness and the fatigued patient all the time. What are your comments and your advice about routine dipsticking and then following up with an MSU, particularly early in the course, because you're telling us that the great importance of an early diagnosis? Are we needing to do more of these? Do we add in the MSU? What impact will we have if we test more urine?
The urine, the beauty about doing a dipstick in your clinic is that you have an instantaneous answer, because you have a long list, and then it may be 1 or 2 days before you get the opportunity to review your MSSU, depending where you send the test, in what city you and